Good morning, good afternoon, good evening, everyone, from wherever you are joining us from. We thank you for making the time to join us on this monthly's webinar. So welcome to join us. My name is Rose Nzioka, co-chair GDHN, and online is a team that is going to take us through the webinar. Let me remind us that GDHF 2024 is coming. We look forward to seeing you in Nairobi. For those that are joining us in person and those that are joining virtually, we look forward to connecting. Please do remember to take advantage of the discounts because late registration fees will be applying very soon. Thank you, and I'll hand over to Mala to take us through the webinar introduction.
Thank you, Rose, and hello and welcome everyone. My name is Marla Shavitz. I am the Director of Digital Strategy at Johns Hopkins Center for Communication Programs. I'm happy to introduce today's topic and today's speakers for the webinar, Improving Maternal and Child Health Behaviors in Mayan Communities Through Digitally Enabled Home Visits. First, I wanted to give you a very brief background on Johns Hopkins Center for Communication Programs. We were founded more than 30 years ago to recognize the crucial role of communication in public health. We believe in the power of communication to save lives by enabling people to adopt healthy behaviors for themselves, their families, and their communities. Our strategic innovations are evidence-based, people-centered, and results-oriented. CCP is part of Johns Hopkins Bloomberg School of Public Health within the Johns Hopkins University. We are the school's largest center and the largest center of its kind based in an academic institution. Today's presentation is about work that is taking place on the Breakthrough Action Project. Breakthrough Action is an 8-year cooperative agreement funded by USAID to lead social and behavior change programming around the world. Breakthrough Action is currently working in 28 countries, and since July 2017, the project has worked in a total of 45 countries. And one of those countries is, of course, Guatemala. So let me kick off today by introducing the speakers, my colleagues Ana and Carmen. I also want to briefly introduce the other panelists who work on the team: Claudia, Maritza, Rob, who is the team leader, Maria Elena, who's a senior scientist in the Department of Health, Behavior, and Society at the Bloomberg School of Public Health and is the principal investigator for Breakthrough Action Guatemala. Our first speaker is Ana Luisa Esquivel, and she is the private sector engagement advisor for Breakthrough Action Guatemala. Ana has more than 20 years experience in business and finance, specializing in marketing and evaluating investment projects in Mexico and Central America. Her areas of expertise include a deep understanding of massive consumption markets, consumer behavior, and communication strategies. Since 2015, she has worked in the social development sector, where she oriented her expertise into brand positioning, fundraising, and engagement with corporate and individual donors. For Breakthrough Action Guatemala, she leads the development of a campaign and a health brand with 5 large private companies titled Protectoras Unidas to help reduce chronic malnutrition. Ana, over to you.
Thank you. Thank you, Marla. Hello to all of you. It's my pleasure to be here and talk about improving maternal and child health behaviors in Mayan communities through digitally enabled home visits. Let's start. The next slide, please. Breakthrough Action Guatemala is a social behavior change project that aims to increase the practice of more than 20 priority behaviors to improve child and maternal health among families living in the Western Highlands of Guatemala in Central America. The chronic malnutrition is about 59% among rural children, the highest in Latin America. To achieve this objective, the project uses several tools and activities that include home visits to families enrolled in the project, conducted by community facilitators that use a tablet and an application called Juntos Prosperamos, currently used by 143 community facilitators to provide counseling and unhealthy behaviors in more than 3,000 families in a monthly basis. La Voz de las Abuelas, involvement of grandmothers in the household, Diálogo de Saberes, engaging community leaders to mobilize the community, Radio novel La Chispa del Cambio, promotion of a series of behaviors related to health and nutrition. Entre Nosotras, mother-to-mother support groups. Padres Presentes, men's circles to discuss responsible and positive parenting. And Protectoras Unidas, a health brand and media campaign co-created with private sector. The next, please. Breakthrough Action has developed tailored counseling to improve the health and well-being of pregnant women and or women with children under 2 years of age by promoting key behaviors across health domains. For example, pregnancy care, breastfeeding, complementary feeding, wash and wash baby. The next, please. Our work in the field made possible by our partner in the community, ASEXA, a Guatemalan NGO that works mainly in the highlands of the country with Mayan population and is the BA sub-awardee for local implementation. The next, please. Now we see the structure of the team implementing the home visits program as follows. The blue level, 2 operations manager, 1 per department. Huehuetenango, the one in blue, Quiché, the one in green. Next, the green level, 11 SBC officers, 1 per community, each one supervising 12 community facilitators. Yellow level, 143 community facilitators who provide counseling to 20 to 25 families in their country. And last, the pink level, more than 3,000 participants or households, which include pregnant women and mothers of children between 0 and 23 months. The next, please. Let's hear now from Victoria Marcos, our operations manager in Quiché.
Mi nombre es Victoria Marcos, soy gestora de operaciones de ASEXA, socio implementador del proyecto Breakthrough Action en Guatemala. Superviso la implementación de las intervenciones de cambio social y de comportamiento en 5 municipios del departamento del Quiché, una de las 2 áreas geográficas del proyecto. A mi cargo está el equipo de campo, que se integra de 5 técnicos en cambio social y de comportamiento. Cada técnico tiene a su cargo un promedio de 10 facilitadoras y cada facilitadora atiende a 25 familias aproximadamente, cubriendo un total de 1,250 familias. Uno de los pilares del proyecto para apoyar la nutrición y la salud de las familias son las visitas domiciliarias que realizan las facilitadoras comunitarias. Las facilitadoras son mujeres voluntarias que viven en la comunidad, que atienden y hablan el idioma local y quienes fueron seleccionadas por los líderes comunitarios en el Quiché. Además del español, hablamos idiomas mayas en las comunidades que atendemos, el Ixil y el Quiché. El proceso de formación de las facilitadoras comunitarias ha sido continuo desde el inicio del proyecto y muy relevante para su capacitación en temas de salud y nutrición y para mejorar sus habilidades de comunicación interpersonal. El uso de la aplicación Juntos Prosperamos ha permitido al equipo de facilitadoras comunitarias hacer su trabajo con más confianza en sí mismas, utilizando la tecnología para brindar consejería, usando contenidos digitales atractivos y permitiendo una interacción dinámica con las madres, muchas de las cuales no saben leer y escribir. El trabajo de las facilitadoras comunitarias representan cambios positivos en la vida de los niños y niñas de nuestras comunidades. Sus acciones han sido visibles a través de los cambios observables en las prácticas de las madres y sus familias, incluyendo una mejor alimentación infantil y mejores cuidados e higiene en el hogar. Las facilitadoras comunitarias se sienten orgullosas de lo que han aprendido, incluyendo el manejo de la tablet. Las facilitadoras comunitarias son lideresas de su comunidad. Su motivación es ayudar, aprender, ganar experiencia y poner en práctica lo aprendido con sus hijos y familia. Es notoria la preocupación de las facilitadoras comunitarias cuando las madres que visitan no lo logran o cuando sus hijos se les enferman. Al inicio no fue fácil la realización de la visita domiciliaria. Algunas madres no reconocían su importancia y no daban su tiempo. Al realizar las visitas mes a mes, se dieron cuenta de lo significativo que podía ser. Las madres cuentan ahora que les gusta recibirlas cada mes, pues les despierta la mente y las invita a practicar los comportamientos recomendados. Es la manera de mostrar el amor que ellas tienen por sus hijos. Por último, y muy relevante, la visita domiciliaria se ha vuelto un espacio recreativo que rompe un día normal e invita a otros miembros de la familia a participar, como las abuelas y las tías, y eso hace que nuestro trabajo tenga más valor. Hacer uso de la aplicación Juntos Prosperamos ha permitido llevar la consejería de forma innovadora y que el impacto de nuestro proyecto sea aún más grande para todas las familias con las que estamos trabajando muy de cerca. Muchas gracias. Mi nombre es Victoria.
Well, thank you, and let's continue. In order to provide a tailored counseling for mothers, the Juntos Prosperamos app was developed to help facilitators conduct these sessions with pregnant women and children from birth to when they reach 2 years old. To provide an adequate counseling on the more than 20 key behaviors, it requires information appropriate for the pregnancy stage of the mother and the age of the child. To assist with this, we need to leverage technology that will allow the use of multimedia formats to present complex themes and wealth of information to address each health behavior. By using the app, the facilitators can easily access the content needed for the mother of the child and help engage mothers with audios, videos, and visuals. The next, please. Besides the benefits to the families through the use of the app, the community facilitator gained recognition, credibility, and status within the community as a reliable and accurate information and an inspiring force for change. Let's talk about our version number 1 of the app. Breakthrough Action started using the Juntos Prosperamos app in October 2021. The community facilitators, most of whom were using the tablet for the first time. In addition, the counseling sessions for the community facilitators were asked to use monitoring formats to track their home visits and collect data on families and children as part of the program monitoring activities. The app and the monitoring forms were separate application in the tablet. The second one is housed in Kobo Collect Toolbox, which added time to the home visits and loss of participants' attention. In August 2022, PA began the process of redesigning the app to improve the user's experience, time, and effectiveness. The next, please, Marla. In January 2024, after usability testing by a group of community facilitators, we launched Juntos Prosperamos app version 2.0, which included important improvements to correct the problems of the original version. The most relevant ones are: in a home visit session, the community facilitator automatically accesses the technical information she needs for that visit, and at the same time, she can record the visit's key monitoring data. Easier management of the 20 to 25 families each family is responsible for visiting every month. Key information from the previous session is displayed for a proper follow-up. A summary of the evolution of the session can be displayed, the content covered, and the duration of the session. The application works offline, and when it is connected to the internet, the information can be updated immediately. The next, please. The application is used to register new participants to join the roster of families in the program for the home visits and collect the key information about them as the visits progress. Once a child turns 2 years old, the family is graduated from the program. Let's walk through the Juntos Prosperamos app version 2.0. First, as you can see in the picture, we identify the family's profile. which can be a pregnant woman, a lactating child, a mother with lactating child, or a mother with a child on complementary feeding. The registration of the family information includes information on the mother and the baby, household composition, household conditions, media access and use for radio, TV, mobile, and social platforms, and very important, the GPS home location. The next, please. The counseling modules on the app are organized into 6 modules. That includes care and feeding for pregnant women, exclusive breastfeeding, complementary feeding, family planning, hygiene, water and sanitation, healthy, clean, and caring environment. Each module uses the 4A's methodology in Spanish, which are analyze, learn, there, and advance. The next, please. Based on each specific profile already registered, pregnant, lactating, or complementary feeding, the app will automatically program the content that the community facilitator will deliver to that mother in her monthly sessions. For example, a pregnant woman will receive 9 sessions, modules 1, 2, 5, and 4, topics that we are going to share with her. For example, danger signs for pregnant women, colostrum, spacing pregnancy. A woman with lactating children will receive 6 sessions, modules 2, 5, 3, and 6. Topics: hand washing, 3 food groups for complementary feeding, house is clean and tidy. And when woman complementary feeding children, she will receive 18 sessions, modules 3, 6, 4, and 5. Feeding your baby according to age, raising with love, use of latrine, pregnancy spacing. If a mother is registered in her first month of pregnancy, she will receive a total of 33 counseling visits. Thank you. The next, please. Well, as you can see, this is our new app, and its sessions average around 30 minutes. The modules include quizzes, videos, and pictures designed to engage our mothers. The next, please. One of the most important parts of the session comes at the end. Mothers are asked to make a commitment, a behavior she would like to practice, to take action before the next month. The community facilitator enters this in the app, and then she will follow up her at the next session. Examples of commitments are fill out emergency plan, go for a and C, take child for growth monitoring visits, give newborn colostrum, feed the child with egg, cheese, liver, or meat every day, talk with the spouse about using family planning. The next, please. Now, this is an example of how the community facilitator is collecting valuable information on a monthly basis to ensure mothers and their children remain healthy. Identifying, in this example, danger signs, allow the facilitative communicator to motivate the women to seek health care. Here we can see how to register if there is a danger sign for the mother or for the baby. The community facilitator asks the women to seek care, makes a reference, and the following month, the community facilitator asks the mother if she went for care, what type of care she received, and repeats the cycle the following month. Same process established for the possession of a health card for the mother and for the baby, an emergency plan for pregnant women. The next, please, Marla. This section provides to the facilitators with general information about each mother who is attending, what session is being given, how many are left. There is no longer need for paper notes, and the community facilitator carrying flip charts for the topics she addressed during the home visits. Now all is in the tablet. The content of the session to be delivered can be prepared by the community facilitator in advance. He has a library of all the content of our 6 modules. It is very easy to see in the session how it was delivered, if it was delivered as planned. If all the boxes are painted in green, that means the session has been delivered successfully. The next, please. What are our challenge and lessons learned in this version 2.0? First of all, it was very hard to find an app developer in the country. We need to embrace a process of mutual learning to ensure the app is delivered in terms of content and our data needs. We have, mainly from the older community facilitators, a highest need for training. We need to create opportunities to test the new app as many times as required. And at the same time, ongoing training and supervision are required to ensure our data quality. And last but not least, connectivity, still being our biggest obstacle to overcome. We need to work with local companies to get a stable signal. And of course lots of patience to find the right time and place for our team to transfer the data. Thank you very much. Over to you, Marla.
Thank you so much, Ana. Next up, we have Dr. Carmen Cronin, Assistant Scientist at Johns Hopkins University, Bloomberg School of Public Health. Carmen is an assistant scientist. Her work leverages research to design, implement, and evaluate social and behavior change interventions to improve the lives of girls, women, and families around the world. Carmen, over to you.
Thanks, Marla. I want to spend a few minutes talking about the monitoring and data implications of using the Juntos Prosperamos application and the tablets in general. So next slide. I want to start by walking you through the 3 pillars of our monitoring ecosystem. The first pillar is data entry. So once a community facilitator is done using the application, whether that's to enroll a new participant or to, she just finished counseling one of the mothers, she can send that data directly to our server. And usually the community facilitator will do this every day right after the visit, although there are some who live in areas with less stable internet connection, and so that might have to be done on a weekly basis or whenever they can get to a spot with good coverage. If the community facilitator encounters any sort of technical issue, whether that's with the actual tablet or the application itself, she lets the SBC officer know. So in Quiche, that would be the SBC officer who would then talk to Victoria, who we just heard from, and she will notify the monitoring team, and they will help to sort of figure out what the issue is, whether the tablet needs to be updated, or maybe it's an issue related to that internet connection. The second pillar in the middle of this diagram reflects data processing. So the data that we get on the server, it's coming in every single day. We process and we validate that data in our monitoring team on a regular basis. We run consistency checks. We identify duplicate entries, which sometimes can happen because that internet connection is unstable. We also identify any missing or anomalous data, and in these instances, our monitoring team will reach out to the field teams specifically to try and figure out what's going on and how we should handle that missing data or that duplicate entry or that anomalous data point. Our team has also created a data warehouse where we can store a complete copy of our raw data set and run analyses on that copy without having to worry that we might accidentally alter the raw data file in any way. And in that data warehouse, we also store other project data sets that we have. And the idea is then we can merge the data from different project activities and run more interesting analyses. So not just the data that we get from the application, but from also some of our other activities. And then the third pillar of our ecosystem involves the data analysis and reporting that we do. Our team has developed a number of interactive dashboards that use Power BI or Google Looker Studio to track the home visits, as well as the key indicators that we have to report back to USAID. We also run additional analyses using Stata, Python, and other packages to really better understand what we're doing in the ground and what effects those visits are having on our families. Next slide. Because the new version of the Juntos Prosperamos application integrates both the delivery of that counseling content, which Ana walked us through, and also the routine data that we want to collect about the home visits and those participants, we really create an opportunity to monitor data in real time. Here, what you can see is one of those Power BI dashboards I mentioned our team has created. This was led by Jorge Garcia. He created this really to help us track the home visits and who we're reaching every quarter. There's a lot of data on here, but Marla, if you could click, I just want to draw your attention to this yellow box. This is where we can get a quick sense of what we've done in the last 3 months. So this covers July to September of 2024. And you can see we reached where we enrolled. We had 3,850 families enrolled in the home visits program. And of those, 3,465 families had received at least one counseling visit in that 3-month period. We can also see that we reached 3,289 children under the age of 2 and 458 pregnant women. So hopefully this gives you a sense of the volume of work that our team is doing on the ground every single day, just sort of the size and the scope of the work that we're doing. Next slide. So real-time monitoring plus a feedback loop allows us to really enhance the quality and the completeness of the monitoring data that we have. I already mentioned how our field and our monitoring teams are constantly talking to each other to address any issues that arise in the field, specifically when it comes to using the tablet or the application, but also when we're processing and we're analyzing our data. If there's anything that looks a little bit odd, we go directly back to our teams in the field to kind of figure out what's going on. So in addition to all of that, our monitoring field operations coordinator, Jose David Mendoza, regularly leads what he calls salas situacionales, or situation room sessions. So these are just meetings with our operation managers and the SBC officers who oversee those 11, each oversee about 11 community facilitators, and they review the progress of the field work. You can see a couple of the photos of them gathered around a table on the right-hand side of the screen. They also review the quality of the monitoring data. They talk about issues that have happened in the field, in particular those that seem to be occurring again and again, and they start discussing also potential solutions to those problems, right? So how do we mitigate any of the issues that we seem to have over and over again to improve the quality of the monitoring data we have? And for these sessions, the monitoring team has created municipal level dashboards using Google Looker Studio. And so you can see an image of one of those dashboards on the left-hand side of the screen. And this allows our operation managers, as well as those SBC officers, right, those supervisors for the community facilitators, to get a better sense of how their specific team of community facilitators are progressing in their work. And we found that not only does this feedback loop, again, enhance the quality and the completeness of the data that we have about the home visits, but we've found that our teams are much more invested and take pride in the work that they're doing. You can imagine that if you're projecting that kind of dashboard on a screen and you're able to see that all 11 of your community facilitators have done the monthly visit that they're supposed to do, that a supervisor would take real pride in seeing that their teams that they're overseeing are really able to complete the job at hand. Next slide. And so the ease with which many of the community facilitators now use the tablets really opened the door for us to use the community facilitators as a mechanism to collect additional data, specifically on the key behaviors the project is promoting. So out of the 143 community facilitators that we have, we selected 42 of them and trained them back in June of 2023 to administer a short questionnaire focused on measuring our key behaviors. And we call this our proxy indicator. So if I use that term, I'm talking about this particular data collected by the community facilitators. So Anna already mentioned some of the key behaviors that we're promoting, but just again, to give you a sense of what we're measuring, things like whether the mother has her prenatal health card, whether she has an emergency plan for her pregnancy, whether she has a child's health card, if she's a mother of a child between 0 and 23 months. We're interested in tracking antenatal care attendance as well as children's attendance at those growth monitoring visits. We're interested in tracking family planning use or intentions to use family planning among pregnant women. We've got a question about dietary recall, which will help us to measure dietary diversity, the consumption of animal protein, and also how frequently children are eating each day. And then there are a series of observations, mostly related to hygiene and baby wash. So have the community facilitators observed any fecal matter? Do they see animals roaming about freely in a household? Is there soap at the hand washing station? And of course, we're interested in the type of flooring and the cleanliness of the floor, specifically where children 6 to 23 are playing and crawling. And so this data is collected on a quarterly basis. The questionnaire is administered after the community facilitator has done her counseling visit. And since June of 2023, we've collected 6 rounds of data. And so you can imagine that this data allows us not only to get a sense of the prevalence of these behaviors each quarter, but by collecting multiple rounds of data, we have the opportunity to conduct time trend and longitudinal analyses to see how these behaviors might be changing over time. And as I mentioned, we're able to merge this data with the household registry data that we have, the data we have from each of the home visits, and we can use that to explore whether those home visits are having a positive effect on the adoption of these key behaviors that we've been promoting through the counseling that is provided by the community facilitators. Next slide. So the home visits, as well as other breakthrough action activities, have really emphasized the importance of feeding children diverse diets. And to measure dietary diversity, we looked at the consumption of 5 different food groups: animal protein, carbohydrates, fruits, vegetables or leafy greens, and atol fortificado, or fortified cereals. And what you can see is data from June of last year to June of this year. So we've got 5 rounds of data collection on the screen. And overall, what you can see is that children's diets are much more diverse now than they were back in June of 2023. Animal protein consumption has increased from 62% in June of 2023 to 80% in June of 2024. That's that light blue line. Consumption of vegetables and leafy greens has increased from 47% to 63%, and fruits have also gone up from 41% to 55%. So these are marked improvements, and the data suggests that those home visits and the counseling that we've been getting on the type of food to eat and the combination of foods to feed children is having a positive effect on the diversity of children's diets. Next slide. These data that you see on the slide are from September of 2023, so about a year ago now. And I'm going to talk about this on this slide and the next one. It's a dose response analysis that we did to determine whether there was a correlation between a mother feeding her child a source of animal protein the day before and the mother's level of exposure to the home visits. To assess that level of exposure, what we did was create an index of the total number of home visits that a mother had received. And then we collapsed that into 3 levels using state as X-style command to create low, medium, and high exposure groups. And that's just for ease of interpretation when we're doing this analysis. And what you can see on the screen is that there is a positive association between having fed your child a source of animal protein the day before and a mother's level of exposure to the home visits. We can see that 84% of mothers who received 9 or more home visits fed their child animal protein the day before, compared to 61% of mothers who had received only 1 to 7 home visits, right? So this suggests that our home visits are having a positive effect on the adoption of this particular behavior. Next slide. So the last thing I want to share are two maps that our colleague Sebastián Oliva helped us to create using this dose response data that we just looked at, but this time aggregated at the municipal level. So on the left-hand side of your screen, you can see the prevalence of mothers who fed their child animal protein yesterday by municipality among our low exposure group. So these are mothers who received 1 to 7 home visits. And on the right-hand side, you can see the data for our high exposure group. That was mothers who received 9 or more counseling visits. The municipalities are shaded from light orange to dark purple based on the prevalence of the behavior. The darker the color of the municipality, the higher the prevalence of the behavior. And so right away, you'll notice that the municipalities among the low exposure group are generally lighter in color, whereas almost all of the municipalities in that high exposure group are purple and dark purple for that matter. Some of the noticeable differences just by looking at the maps, I want to point this out. So Marla, if you could hit that first animation, we can see that in Nebach, on the left-hand side, 38% of mothers in that low exposure group have fed their child animal protein. But when we look at Nebach in the high exposure group, 82% of mothers are doing this behavior. In Chahul, so if you could click Marla, we see that in the low exposure group, it's 55% of mothers who are feeding their child protein the day before, but in the high exposure group, it's 85% of mothers in this municipality. Marla, if you could hit it again, let's look at La Democracia. That goes from 55% in our low exposure group to 100% of mothers doing this behavior in the high exposure group. And even municipalities that are doing well in the low exposure group, like Quidco. So if you could hit that button again, Marla. We see that 75% of mothers are doing this behavior already in that low exposure group, but 100% of mothers are doing this when we look at the high exposure group. We can also see from this map the municipalities that are maybe lagging a little bit. For instance, something is going on in San Sebastián, Huehuetenango. So if you could hit that slide again, Marla. Oop, I think we need to go one more. Let's go again. Let's Quilco, keep going. There we go. So here's San Sebastián Huehuetenango. So it's doing not too good. You could hit that again, Marla. Not doing too well in both our low and our high exposure groups, right? So it's just something for us to consider. So these maps, I think one of the benefits is that they're visual and they're more intuitive in some senses, right? We can get a sense fairly quickly of where our counseling visits appear to be making a difference and where those ones are not, where that doesn't seem to be the case. And so while these comparisons are not statistically done here, it still gives us something to consider, some things for us to further explore, both programmatically and maybe with additional research. So I hope that what I've shown you in the last few slides provides you a little bit of an overview of the monitoring system that we have in place and what we've been able to do with the data that we can collect, both from the use of an application like Juntos Prosperamos and just the use of tablets in general, in terms of that real world, real-time monitoring that we can do. And also, hopefully, I've shown you a few ways in which we've been able to leverage that data to understand what's happening in the field in terms of the volume of work that we're doing, as well as the effects of the home visits that we're implementing and what adjustments we might be able to make to improve the project's effectiveness. So I'm going to take that back to you or hand it back to you, Marla.
Thanks, Carmen. I do see that there is a question. So I will start with Anna. Will we have access to the webinar? Yes, there's a recording that will be sent out. And then the tools, which makes me wonder, and if you could help me answer this question, how does the team get access to the app? Are you handing out provisioned devices? Are they downloading it from an app store? How does the team get access?
Well, I can explain, but of course, my colleagues can have a deeper answer on this. All of our team has access to different dashboards, as you can see. Carmen mentioned give some examples. And in that kind of dashboards, we can see all the detail. As mentioned, as soon as our field team have internet signal, they can send all the information. And we can see in matter of minutes the updated information. So it is available for all the technical team, and also in different levels of information, the field team can also see this information.
So the app is downloaded, I think through Google Play, if I'm not mistaken. And so that's how we make sure that the tablets all have the correct version of the application loaded onto it. I think in terms of access, I know the question was about access to the webinar, but maybe I think the question was asking about access to the application. And we certainly have had requests about whether or not this can be shared with other organizations in Guatemala. And I think that's something that the team is looking into at the moment. I mean, we would love to see this have a life beyond the Breakthrough Action project. I think one thing to keep in mind is that the counseling content is very much tailored to the Guatemalan context. Ana had talked about how not only is the content in Spanish and all of the images and the videos are meant to reflect the context and where we work, but we've also translated a lot of this into the local languages. And so I think in terms of the more widespread use of this application, we'd have to think about how it could be tailored to meet the needs of other cultures and contexts. But I think we would certainly be interested in having this have a life beyond this project.
Yeah.
So I wanted to leave time for more questions. So I see another one coming to the chat. Excellent. So how did you connect the app to Google Looker Studio to create data visualizations and dashboards?
Yeah, this is a great question. So we didn't connect Google Looker Studio directly to the application. Rather, I mentioned we have this data warehouse. So the data from the app does get loaded into our server and we can download that. And we've made a copy of that raw data in the data warehouse. And from the data that we house in that data warehouse, we can then plug that into Google Looker Studio or Power BI. And so it's not connected directly to the application, but rather to this data set that we have, sort of in an intermediary piece between what's on the actual application and these interactive platforms. But we certainly have to give a shout out to our monitoring and evaluation colleagues for setting up those different dashboards. I think you can see just from the presentation how useful those interactive dashboards are, not only for us in sort of keeping track of the work that's happening, but also for our field teams who can better monitor the work that they're doing and the teams that they're overseeing.
Thanks, Carmen. So there's another question. Why were only 42 community facilitators selected to collect data?
Why? Well, this is when the project started, first we map geographically the departments, the municipalities, and the communities. And this is the selected areas where we wanted to implement. The selection of these areas were aligned to the health ministry and of course with USAID. So of course it can be larger, but this was the agreed area of implementation of our project. But for example, I think we can say that we are able to have an expansion geographically if we can do that. Now we have all the resources and the knowledge to do that.
I want to add to that answer, Marla. We have about 142 or 43 community facilitators in the 11 municipalities that the project works. So what we tried to do was to create a sample in every municipality of community facilitators that could collect that additional data that Carmen called, that we named the proxies that she referred to at the end of her presentation. And these community facilitators were selected also based on their educational level, because as you can imagine, learning how to work all these questionnaires in a tablet, it's a little bit of a challenge when we're thinking about volunteer community facilitators. And so we try to collect the data to provide USAID with ongoing information about what the project was accomplishing on key behaviors that the program and USAID were very interested on. So that's how the number came about.
Thank you so much. Are there any other questions? Great. So bravo for all the work that this team has accomplished. Did you start comparing data from community and health facility, for example, to demonstrate adherence to ANC or to family planning at health facility from home visit referrals?
That's a great question. We have not compared our data to health services data. That's certainly something that we could look into to kind of get a sense of maybe how our communities are faring compared to the community at large. But no, that's not something that we've done as of yet.
Thanks, Carmen. Another question, did you collect a baseline before you started the intervention? Do you have the end line that shows significant progress? And then apologies for losing connection. If you could address that.
Yeah, it's another excellent question. We don't have a baseline per se. We don't have a sort of final evaluation end line planned for specifically. The data that we were sharing today is very much monitoring data that we use to actively get a sense of sort of how we're progressing and what adjustments we can make along the way. However, we did collect some additional data with an external agency. We collect this monitoring data that we do on an annual basis, and we use that in the second year of the project as sort of a rough baseline for us to establish metrics each year in terms of sort of the progress that we want to see made within our project communities. But the data that we've presented today is very much in our eyes monitoring data. We are looking to do a sort of final round of data collection with this external agency, hopefully with a group of communities that participate in our intervention, as well as communities that are not participating in our intervention, to have at least some sort of comparison group to be able to speak more to the effectiveness of our activities, not just the home visits and the counseling that we've been doing, but some of those other project activities that Anna mentioned at the very beginning of the presentation.
Wonderful, thank you, Carmen.
Yeah, and just to add to that, Marla, also, the project was not asked by USAID to evaluate the activities, but there is an external organization that is doing a much larger evaluation of this project and another project that is related to health services. So there is a baseline that comprises the two projects, and they will be an end line in the near future of the two projects. But our data, as Carmen says, gives us an idea of how the program is progressing so that we can take action immediately every quarter. When we prepare the quarterly reports, we have our lessons learned from the data, and then the programs are revised, improved, reinforced to continue to show changes over time, as Carmen was showing in some of the examples that she shared.
Thanks, Maria. All right. Any last questions? Well, I wanted to thank both presenters, Anna and Carmen, and the whole Breakthrough Action Guatemala team. This has been a real pleasure to dig into this. It's such a robust project. So it has been really wonderful to spend this time with you all. And I wanted to thank everybody for attending today. Have a great day.
Thank you.
Thanks, everyone.
Thank you.
Thank you.